see. So if you want to have a short treatment, you go for lingual braces, and they are totally invisible. You don't see anything, right? Here, it's slower, yeah? So it takes longer. They are not fully invisible because you see the attachments, you see the plastic material. So, you know, it's like not a fully invisible choice, but yet, you know, some patients like the idea of the removable brace, so they might go for the aligners instead. Looking at the literature, again, you have to be honest. You know, we know that there are many limitations with the aligners, and this has been published in the last years really well. We know we might only get some tipping movements. We know that our treatment planning and the final result, they do not match 100%. So what you're planning at the computer, at the software, it's not exactly what you get at the end of the treatment, yeah? And as I said, this has been highly written and discussed, you know, in many articles. Yeah, so just look at the recent literature. This is another good study you see from Zurich, and yet they say fixed braces are still superior, you know, to the use of aligners. But you know, you can combine the two of them. So if, for example, you know that there are some limitations depending on the movements, yeah, you have to perform, well, you can still combine some lingual braces maybe with the aligners. And this is exactly what we call hybrid treatments. So in my opinion, if I have to deal with impacted teeth, torque, or extraction cases, which is also related to the torque, uprighting of molars, huge rotations, you know, these are difficult movements for the aligners, yeah? So honestly, I tell the patient, you know, we should do this with something else, maybe with a sectional, maybe with some lingual braces, maybe with an uprighting spring, maybe with the mini implants, yeah? So honestly, talk about, you know, the limitations of any system. Yeah, yesterday we had this beautiful lecture by Professor Lee, who is even a great singer, on impacted teeth and transposed teeth. He gave a beautiful lecture about the biomechanics, and I was so glad because for me, biomechanics still is, you know, the number one, rather than the appliance. So if I have an impacted tooth, an impacted canine or premolar or incisor, honestly, rather than thinking about the type of brace, I will focus, you know, on the biomechanics, on the anchorage, yeah? And I know that if I do it, you see, with some kind of segmented technique like this one, this is a cantilever over a mini implant, this is much better, you know, it's more efficient. So let's see this example. Yeah, this is a nice case. Young man, very good bite, you know, it's a class 1 with some diastemas and initial gingival recessions. Yeah, we will talk about recessions very soon. You see mainly at the level of the premolars. Gaps are there, but the canines, you know, for some reasons they didn't erupt. Lovely occlusion, class 1, normal overbite, and both canines are in a palatal position. Yeah, so this is good indication to take some radiographs. The CBCT, of course, would be highly recommended, but even from the OPG, you see that the canines are basically next, you know, to the suture. Yeah, so pretty much in the center of the palatal roof. Not too difficult yet, but we have to be, you know, cautious and approach with correct biomechanics. So in this case, you see, rather than start maybe with whatever aligners and tats, I prefer to go for lingual. I know I can get a better result with lingual braces. So after the initial phase, alignment and leveling, I start making space with the push coil over a stainless steel wire, and then it's time for the surgical exposure and, of course, the biomechanical traction. Yeah, so remember what Professor Lee said yesterday. The traction is extremely important. Yeah, so you have to know how you are pulling the tooth. The force vector is extremely important. So here, you see I'm working from the inside. This is a cantilever, TMA wire 1725, active for vertical extrusion only of the, in this case it's the right canine. Yeah, so it's just a vertical single force, very light. Yeah, we are talking about 10 grams, 10, 15 grams. And then I will do the same as well on the left side. Yeah, so there will be a time when the crowns are visible. Most of the times the crowns are rotated. Yeah, so you have to bond up some brackets and do some derotation mechanics. And this is another limitation for aligners. So I know that if I have to derotate, in this case both canines, this is done much better with like brackets, wires, maybe power chains, yeah, to get some, in this case, an anti-clockwise moment. In this other case, it's a clockwise moment. Piggyback technique as well. You know, this is more efficient and even faster than probably using aligners. And then ready for the finishing. I'm doing a lot of wire bending and the adult treatment, and this is the final result. Well, maybe the canines are a bit, you know, tipped out. Probably some buccal root torque would have been a good idea, but the patient was extremely happy, so he said, you know what, I'm not really having a longer treatment, I'm happy with this result, and I think I totally agree with him. It was quite a good result. You see, recessions didn't get worse, so we were very lucky with this type of approach. Of course, bonded retainer for the rest of his life, a removable retainer at least for 2 or 3 years, if not longer, and this is the final X-ray. So likely very little or maybe no root resorption at all. This is last time I saw the patient 3 years later. You see the occlusion is still stable, canines are still in a good position, and recessions are quite stable after 3 years. He just broke the upper bonded retainer, so I remember I made a bit of a repair between the upper right 2 and upper right 3, but otherwise you see everything was pretty good. This is another case, yeah, similar. We have a baby canine there, on the left side, yeah, so this is a baby tooth, and you see the permanent canine is actually impacted and blocked by the presence of the baby tooth. The guy doesn't have good anchorage posteriorly. You see, he is actually a candidate for some implants and maybe some crowns. So I really don't want to use the molars for my orthodontic traction. Yeah. So in this case, I think the best would be, rather than using maybe some aligners at the start, you know, go for a good anchorage like a mini implant, and then of course the baby canine has to be extracted and the permanent canine has to be exposed. Yeah, you can do the same in same approach in the same surgical exposure. So you see the baby tooth now is gone. We have the permanent canine to be bonded up with some gold chain or maybe a button. Yes, and this is my anchorage. Yes, so we have an Ortho Easy mini implant. This is 8 millimeters, which will be, you see, pretty much parallel to this premolar. And that's it, you know, I'm using the same mechanics as in the previous guy. So TMA wire 1725. This is a cantilever. So it's active for vertical extrusion of the canine. Normally it takes 4 or 5 months, yeah, to get the canine down, and then when you see the crown, it's time to move on to the piggyback technique. Yeah, so I will do my finishing with the piggyback. You see 2 wires to control the rotation of the tooth, and then finally the tooth will be in the arch. And of course, it's as I said, it's a case for implants, you know, guided bone regeneration, and later on implantology. Now, another indication, in my opinion, for fixed braces rather than aligners is torque. Yeah? There is a lot of discussion, is it possible to control torque with the aligners or not? And if you look at the literature, it's still uncertain, I would say, or we know that we mainly get tipping rather than torque. Okay, so if torque is the priority, like extraction cases, or if you have gingival recessions, we mentioned before, these are, in my opinion, cases you should do with the fixed braces. For example, you see, this lady came with a classical deep overbite, class 2, division to malocclusion. I mean, look at the torque of these incisors, yeah? They are all retroclined, all of them. Yeah, from this side to the right side, all of them. Totally retroclined, there is no grounding, yeah? So you cannot do any proclination. This is purely torque mechanics. So in this case, rather than aligners, this is normally what I do. I will go for a torquing wire, which is this one. This is another TMA wire. It could be even in lingual technique, it could be 17 by 17, for example. And if you look at this bracket at the top, you can see the inclination of the bracket. Look at that. You see, you get a lot of palatal root torque when you give this particular opening curve plus, the twist in the anterior area of the wire. Yeah, you see the bracket will do exactly this movement, which will deliver, of course, some palatal root torque to the teeth. And you can see the teeth, they change a lot. Although the patient was wearing class 2 elastics to work on her bite, and this is indeed, you see, the end of the treatment. Yeah, so it's quite a big change. You see the torque from the start to the intermediate stage until the end of the treatment. This is proper torque. It's positive torque, which was delivered by the wire, by the twisting of the wire. Another indication, we said recessions. I see this a lot. Even in the previous lecture, you saw it, yeah? I treat adults, so my life is dealing with difficult patients. Difficult. Adults are demanding. And this is not the case of mine, but she came to my clinic for a second opinion. She was in treatment. What do we do here? I'm working, with probably one of the best periodontists in Italy, Dr. Casentini, but even my friend Paolo Casentini said, this is not an easy one. I mean, you can take a CBCT, but even clinically, you see, the root is out. The root is out. So he said, can you torque the tooth? Can you deliver some lingual root torque here or not? But is it the case for aligners? If the patient wants aligners at this stage, what do we do? Do we go for aligners or not? Or do we stick to fixed braces? Yeah? So it's out. It's out. Of course we can try to do some lingual root torque, but it doesn't mean that you get full healing of the defect, of the recession. Yeah? So these are the classical articles. You have the literature. I studied in Denmark with Professor Meltzen. This is one from Aarhus University. So here, of course, Professor Meltzen claims that lingual root torque is highly indicated whenever you have recessions. You see? So you can get, in some patients, quite a good healing, even without any connective tissue graft. And you can do it, just with the straight wire approach, or even with the segmented approach, like in the picture number B. Yeah? We know that. This is the segmented approach by Professor Metz, and you can see before and after. Well, maybe it's not perfect, yeah? We still have a minor defect there, but it's acceptable. And then we will ask the patient, would you like to have a graft or not after, torquing the root lingually? So these, for me, are again indications for fixed braces rather than aligners, yeah? This is what you see, actually this is from Instagram. You see, this is a very famous orthodontist from Brazil, Daniel. He had this recession at the top, yeah? Aligner treatment, and he was showing, the torque of this incisor using the aligners, yeah? You see, I mean, the recession is still there, even after 4 or 5 months of treatment. And again, I'm not criticizing anyone, I'm not. I'm just saying that even if you plan this amount of torque on your software, yeah, on your digital software, unfortunately, what you get is very little. It's very little, you see? Before and after, yeah, you have some improvement, but it's not, what you get with a torquing spring or fixed braces, yeah. So let me show you this example I did with Paolo, yeah? So it's a retreatment. The patient actually has a bonded retainer. All of a sudden, she got a huge defect, you see, huge recessions. And the funny thing is that she was so stubborn, I want aligners. I want aligners. That's it, yeah? You have to be honest. You tell the patient, we will get very little with the aligners. So you need, of course, a grafting approach, yeah? Grafting technique. Yeah, you see, she had even an old fixed retainer there. So of course, after the initial assessment, the initial records, you can see roots are completely out of bone. There is really a huge defect in that area, and they are protruded, yeah, they are protruded. Paolo said, I will start myself doing my approach, periodontal approach with the connective tissue graft. I will show you the protocol very soon. And after that, if the patient wants aligners, we will go for aligners. But she has to sign a good consent that she is aware of the limitations, yeah, if we treat her with the aligners. Right, so Paolo started with this initial approach, scaling, root planing, chemical treatment of the roots, and then, of course, the connective tissue graft will be placed right there, and is using that together with the endogate, yeah? So, overall, I think the outcome was good, was not amazing. You see, it's okay, it's good. And then, yes, we were ready for the aligners. So, of course, I tried, to ask the lab, please, I need some lingual root torque here on the lower incisors. We did a bit of in the proximal reduction as well. Tried, to torque the roots as much as possible. But what I'm telling you really honestly is that you don't get the same as with fixed braces, yeah? So this is how we ended up after the use of the aligners. Paolo was still checking the probing depth, and you see after treatment is actually not too bad. There was a bit of, even a little bit of root resorption, as you see, and the end of treatment. But you see, before and after, well, there was some improvement, not amazing, yeah, even considering that the graft was done, but this is quite interesting. So if I look at these pictures, before and after, so this is the patient when she started, yeah, with these roots completely out of any tissue. This is at the end, much better. And I'm not saying this is torque, yeah? I don't think it's torque, it's just probably some tipping with a little bit of interproximal reduction. But if I compare before and after, this one still looks much, much better, yeah, than at the start. So combination of periodontal treatment with the connective tissue graft and some aligner treatment at the end. Personally, this is my favorite task. You know, when the patient comes, or she or he will develop all of a sudden a gingival recession, I like to do it biomechanically. Yeah, so I normally use these 2D lingual braces with a sectional night-tie wire under the gingival loop. This is like a torquing spring. So this will move the root away from this defect. Yeah, here we have the defect. The root goes away and it goes into the lingual direction. And you can see exactly the amount of torque, yeah, when you use this double arch technique. It's extremely efficient. You see, so in most of the patients, you see the defect will disappear even without periodontal treatment or surgical approach, and this is acceptable. Yeah, I discussed with Paolo. Paolo said this is fine. She doesn't need anything else from the periodontist. So just ortho treatment was enough here, and now you see the root. This is torque. You see now the root is completely on the lingual side of the arch, which means the defect is still here, still there, but the root has been moved away from the defect. Yeah, so this is when fixed braces or lingual braces or torquing springs are much superior than aligners. Yeah, this is 8 years after end of treatment, and still, it's rather stable. She broke the bonded retainer, but everything is pretty much stable. So coming back to the periodontal management, yeah, Paul is using, of course, the technique which is highly recommended in the literature. It's a combination of a precise grafting protocol, so to say. So you have really to use together, you see, the connective tissue graft and combine it with the so-called endogame. Yeah, we have a lot of literature onto this, and really we have extremely good results. Yeah, so this is just one example to show you the management. Flap design is important, so do not touch any single papilla. Then the flap will be, of course, stretched in the coronal direction. Connective tissue graft is, of course, one of the most important components, and then the use of endogame. Yeah, so when you combine these three components together, according to the literature, you do get extremely good results. Yeah, so if I cannot get, full healing only by torquing the root of the tooth or the teeth, I will then ask Paolo to help me with a connective tissue graft. Yeah? So these are my personal views. Now, we said about, yes, extraction cases, and we know many times we go to congresses, extremely good clinicians, they show extraction cases with aligners. I'm still a bit worried because I'm always afraid of excessive tipping, So if I have to treat patients with extractions, basically this is what I prefer. So combination of mini implants together with some lingual braces. Yeah, this lady was very protruded. Yeah, so she has lip incompetence, very excessive protrusion. So basically she comes for extractions. Yeah. So we did only camouflage treatment, 2 premolar extractions at the top, and this is my classical, biomechanics after aligning and leveling, couple of orthoisimine implants, power arms, and sliding mechanics. But of course, you have to work to maintain the anterior torque, otherwise you will lose torque even with the lingual braces. And this is after treatment. You see it's quite a nice torque at the end, so I didn't lose much torque with the space closure mechanics, and I think this is quite, fair torque at the end, considering how she started. Yeah, good occlusion, and ready for the post-orthodontic, rehabilitation. And this is the other indication, in my opinion, upriding. And so if I have to do upridings, I will then go for upriding springs with or without mini implants. Yeah, I believe that it's really challenging using aligners if you have a molar to be uprided. And yesterday again, Professor Lee showed beautiful cases upriding, very challenging molars. Yeah, so I think either a spring, a cantilever, a double cantilever, anything which will be able to deliver a moment is of course indicated. So that's another indication for fixed braces rather than aligners. Now let's see these hybrid treatments. Yeah, so hybrid means combination of the two. Maybe we do one arch with the aligners, the other arch with the lingual, and possibly there should be a reason behind that. Personally, I think treatment time is one reason, biomechanics another reason, or it could be even the patient's desire. They don't want to have top and bottom with lingual. They're afraid about speech interferences or discomfort, and then they go for one arch with the aligners and the other one with the lingual braces. Yeah. So let's see. Some examples. Let's start with this. This is an easy case. Yeah. So tendency for a class 3. You see, we have edge-to-edge bite here with a lot of trauma on this incisor. Look at the worn out margin. So that's a risk even to lose vitality for that tooth. The patient wants to have some invisible approach. Yeah. So the question is, what do we do? Aligners, lingual, or hybrid? Yeah. So here, this is quite crowded. Yeah. And she said, I prefer not to extract. One option was even to consider one extraction, but she said, no, please try to do it non-extraction. And then, of course, we have to look at the radiographs. Yeah. Up arch is not too bad. Yeah, we have some rotations, which might be a problem with the aligners. But I remember she said, you know what? Even if they're not perfect at the end, I'm happy. I want them to look natural. Yeah, so don't worry if the upper incisors are not fully derotated. Yeah. So we started with this in mind. Then you see she had these old amalgam fillings. She didn't want to make new ones in composite, so that's not a good, indication for lingual braces up there, because they can come off. And then we look at the radiograph, and we see that, unfortunately, roots are not really good. Yeah, they're very thin, even in the lower arch, but especially at the top. Yeah. So I was a bit concerned up there, and I said, you know what, I think we should go for aligners at the top, because it's evidence-based that aligners cause less root resorption. Yeah? Whereas here, in the mandible, we might go for lingual. Yes, so same patient treated, with two different systems. So here I did expansion, some interproximal reduction. I used, of course, a push coil, to make space, and then it's time to bond the bracket on the tooth, maybe not in the perfect position, but you have to reposition the bracket later on until the patient is pretty much ready. Yeah? And the upper arch was done on the other end with the aligners. Yeah? So it took longer, I have to be honest. It took longer, and even at the end, you see the upper laterals are not fully derotated. But she was happy. And she said, I think they look better like this. Although they're not perfect, it's still they're still looking natural. Yeah, so she was quite happy with this outcome, and this is, I think, a very simple approach of hybrid treatment with different type of braces in the maxilla and in the mandible. Yeah? So this was the lower arch, and this is the upper arch, you see, done with the removable aligners. Let me show you another one. This is another interesting case. Yeah, she's a notary. She talks a lot. She makes a lot of money. It's a good job in Italy to be a notary. Yeah. You make millions, yeah? Unfortunately, I know, because anytime I have to buy something, they charge like hell. And she said, I'm not happy with my teeth. I have to talk all the time. Look at my teeth. So she has a lot of calculus, recessions everywhere, crowding. But I said, I'm not starting, with this oral hygiene standards and recessions. So of course she needs a good periodontist, yeah, before she starts any orthodontic treatment. So here, of course, usual approach as we saw before. This is, you see, after the connective tissue graft together with the endogen. We wait at least 5-6 months before we can start with any orthodontic movement. Yeah? So after healing, it was time to scan the patient, take new records. You see, the healing is quite okay. I mean, they improved a lot after the connective tissue graft. So this is now quite an easy case. Yeah, quite an easy case to be treated. And this is now the second. You see, although oral hygiene, even after the periodontal treatment, is very, very poor. You see, she doesn't brush well. Maybe it's because of the crowding, I don't know. But you see, this is not good oral hygiene to have braces. So upper arch is quite okay, but keep this in mind, yeah? This will be the next problem. You see the anatomy of these upper centrals, they are very triangular, yeah? So the moment I will straighten them up, there will be the classical black triangle. And you have to tell the patient, it's even in the animation of the aligners, this black triangle. So tell them in advance, otherwise, they will be very upset. Lower arch is not too bad after the connective tissue graft. So I asked the patient, what do you want? Of course she wants invisible. And then I said, this could be good for lingual. It's going to be quick. Nobody will see anything. But then I said, upper arch, well, upper arch is fine. It can be done even with the aligners, you see. We have some small rotations here at the upper left too. Look at the centrals, you see, they are overlapped. And this is when you will have the triangle during the treatment. So you have to do some interproximal reduction up there and try to get a bit of uprighting of the roots if possible. Yeah, but I think this is great for 2D. I know it's going to be quick and completely invisible. Yeah? So these were the radiographs after the periodontal treatment. She got an implant, you see, substituting the lower right 6. And yes, then we did the scanning at the top, whereas I just started in the mandible, you see, with the 2D. So this is another good point, yeah? You have to wait for some weeks in order to get the aligners back. But in the meantime, while I'm waiting for the fabrication of the aligners at the top, I can start at the bottom with the 2D. And this is ready, it's available in the clinic, so even the next day I can bond up the brackets and start with my movements. Yeah. So I got the planning, the animation, and you can see even on the video, look at that! there is the triangle between the upper centrals. Yeah, so I have to show this to the patient and tell the patient there will be a time that you will end up with a triangle, a black triangle for some time. Yeah, so then you will need, of course, some interproximal reduction and a little bit of, you know, upriding of the roots. Yeah, but this was the first stage. Yeah. You see, they couldn't close completely the triangle in the first place. Then we had to do a second set of aligners, which was actually, you know, better to improve completely aesthetically the area. And this is aesthetics. You see, I'm honest. I mean, invisible for me, it's down here. So the bottom is invisible. The top is transparent. It's not invisible. Yeah. So you have to tell the patient it's not invisible. There are attachments. You know. So it's not, you know, what you see here. Look at this is 3 months, and already the lower incisors are straight. They are leveled. They are straight. But definitely you see the aligner at the top, yeah? So I started like that. The lower arch, you see, was pretty much done after 3 months, even just with the night eye. 1, 2, and then, yes, bit by bit, now you start to see the triangle opening up between the central, so I had to do some filing, some interproximal reduction. But luckily it worked pretty well. So I had to ask for a final series of aligners while the lower arch was done. Yes, it was just like under monitoring. Yes, so I asked for some more aligners, and I did a little bit more of filing at the top for the final adjustments. You see, especially the rotations. Yeah, now we have a wire which is night eye 016 in the lower arch, and you see more and more filing in order to close that black triangle. Yeah? So overall, I think the result was good. So we came to this final stage of the aligners, and then she was finished like this. Yeah. So patient was really happy. Bite is good, everything is fine. She got also some composite by her dentist, just to make the margins a little bit better. And then she should do the same, I guess, even for the lower incisors, but she's considering it. And otherwise, I think this is quite a good outcome of the treatment. Even the bite, you see, is reasonable. Yeah? So I managed to open her bite, correct the crowding, rotations are pretty much done at the top. Definitely better result in the mandible. Yeah? So this is showing once again fixed braces are somehow faster than aligners. Let me show you, and now we move here towards the end of the presentation, some cases of open bites. Yeah? So this is classical young girl with a long face, very long face, incompetent lips, bit of gummy smile, not a lot, but actually what I told her, I said, this is actually quite straight, so it would be nice maybe to round it up, which means you will be more gummy at the end, but we can still do some period the treatment of the gummy smile after end of the orthodontic treatment. Yeah? So it's a retreatment. She had treatment when she was a child. You can see the tongue interference between the incisors, a bit of cant of the maxillary anterior plane. Yeah, so that has to be also fixed if possible. And as I said, it's not really a very difficult open bite. Yeah, so you see the old retainers, which have to be, of course, removed before the second course of the treatment. Here, she lost the retainer, so it moved, and there is as well a bit of relapse of the crown. Yeah. So what we did was, we started with the 2D in the lower arch, and then she went for aligners at the top. Yeah. So this was my planning. Basically, we decided to try some posterior intrusion with the mini implants, but I also wanted to extrude the front, to get a better smile arc, knowing that gums will follow, so the patient might end up with the need for some surgery at the end. Yeah? But overall, you see, this was the planning. And I also did one extra series of aligners, like the finishing set. And the other thing, you see the bite blocks, yeah, at the top. So from the beginning, you can ask the lab, you see, to have bite blocks on first and second molars, just to control the vertical, mainly in the open bite cases, yeah, so to say. Right, so this is before, and you see the animation closing the bite with a combination of posterior intrusion and anterior extrusion. Right, so I started like that. Of course, whenever you have the bite blocks and the aligners, the bite will open up dramatically. So she was not really happy at the start because it's a massive open bite right now. And this is because, you see, because of the bite blocks on 6 and 7, right and left side, so you really open the bite a lot, but that's a good idea to control the vertical position of the molars. The second stage was to have mini implants, yeah, so for a few months I got the intrusion, using just removable elastics to intrude the posteriors, and the patient was quite good at that. And then we moved, towards the second phase of the treatment, which was the use of anterior elastics. Yeah, so see, I started, we removed then the mini implants. Then we started, you see, with buttons, plus even some class 2 elastics, yeah, to work on the sagittal malocclusion. Don't forget, she has lingual braces at the bottom, yeah, so she can pull class 2 elastics even from the inside, if needed, yeah, and then I started to reduce the bite blocks when I was almost at the end of the first aligner set. And now you see, by grinding off the bite blocks, of course, the bite is closing down, yeah? So we are pretty much there. You see the bite is even improving, still a bit class 2, but much better than at the start. Yeah, so I decided to grind off more and more the bite blocks, and then you see now it's actually quite closed. Yeah. So at the moment it's pretty much finished. I'm going to finish next month. We are still seating down her bite at the front with basically with the triangle. Yeah? So she's wearing some triangles here, right at the front, and also some class 2 elastics just to do the final bit of the correction of a bite. Yeah? So this is where we are right now. And I think she did a very, very good job. We just have like 2-3 aligners left. There are not many. This is probably the third last aligner she's wearing. Almost there. Class 2 elastics and some anterior elastics. You see, she did quite a good job there in terms of cooperation. And yes, let me just finish with another good case. This was treated by the FAS team, so Domingo and Alberto. And you know, it's a very interesting case which could be done even by surgical means. Yeah. So once again, an open bite lady, very long face, gummy smile. So the question is, would we go for orthognathic surgery? Yeah, look at the lip incompetence, look at the strain of the mentalis muscle, and look at the profile. Yeah, very recruited. Yeah. So open bite, tendency for class 2. Yeah, this is another, once again, another problem. Huge recession. So could you go for aligners there to torque the incisors or not? Yeah, you have to ask yourself, but be honest to the patient. Be honest. Yeah? If you have a recession, it's not a good idea, you know, to have aligners, to torque that particular incisor, yeah? So much better to go for fixed braces, labial, lingual, maybe a torquing spring. Here, a torquing spring was used, yeah? So this was the planning, and well, they did it with a lot of mini implants. Yeah, so posterior intrusion with mini implants, but not only, even anterior intrusion to reduce the gummy smile, and of course hoping for mandibular auto-rotation. You know, when you intrude the posteriors, of course you try to auto-rotate the mandible forward and close the bite, basically. Yeah? Right, so this was another hybrid treatment, which means aligners at the top, lower fixed braces, labial braces at the bottom. Yeah. So see, this is how they start. 10 mini screws. This is crazy. Yeah? It's a lot to intrude posteriorly, to intrude incisors as well, in order to reduce the gummy smile. But you see, the mandible, they went for labial braces, not aligners, labial, because this was a concern, and there are limitations here using the aligners. Yeah, so labial brackets, they went for a high torque bracket, you see? So they went for this 20 degree, which is actually minus 20, you know, to move the root as much as possible lingually. Already with the prescription, you can get lingual root torque, which was not enough, yeah? So then later on, they had to use a torquing spring. The spring is pushing here, and it will deliver even more lingual root torque. Is it enough? Do we get full healing? Maybe not, but yet you get an improvement. And then you leave the decision to the patient if to have a graft at the end of treatment. Yeah, now you see the root is coming lingually, yeah? That's the sign. Yeah, so after this is quite typical. There is the stop and go. So we scan the patient after 20 aligners, send the aligners to the lab, and we get pretty much like the last series of aligners. It could be, it depends, 10, it could be 15, it could be 5, it depends on the case. And in this particular case, actually the mandible was then treated at the end, you know, even with the aligners. So now it's full aligner treatment, top and bottom, yeah, just to finish the case. You see the recession is still there. So final result, pretty good. You can see the smile is much better. She's still long face, of course, it's not a surgical case, but better lip competence and very good occlusion. You see the recession is still here, but of course she can have now the grafting protocol if she wants, but much, much better than at the start of the treatment. Before and after, you see some improvement of the profile. The mentalis is less strained than at the start. And the smile, gummy smile at the beginning, nice, beautiful smile. At the end with a very good parallelism between the upper anteriors and the lower lip. So just to conclude, so I'm pretty much on time. I like very much, this hybrid or combined approach by using aligners and lingual or labial braces together, mainly because of cost and benefits might be actually a limitation, because the two systems are expensive, especially aligners and lingual. But you try to make a shorter treatment approach, mainly with the lingual braces or labial. You try to overcome, the biomechanical limitations of the aligners, torque, remember the torque, space closure mechanics, uprighting, impacted teeth we saw at the start. So it makes sense, to combine these two different systems together. And of course, when it's lingual with the aligners, it starts to be really invisible and highly accepted by the patients. So with the 2D brackets, I get very quick alignments because of the low friction mechanics, very light forces, so it's really quick to align and level, and then I can move on even with the aligners if the patient wants. Excellent rotational control, so if these are very rotated, I go for lingual braces instead. And both systems, can be combined with cuts. They can be combined with cantilevers, with uprighting springs, with power arms, to improve the mechanics. Thank you so much for your kind attention and enjoy the rest of